Well, thank you very much for inviting me, and it's a pleasure. I've been enjoying listening to Dr. Shinoy and others. So I'm going to talk a little bit about lung involvement, and I'm going to close my video because I am where I am. I don't have very good internet connection, so I apologize for that. But hopefully you are able to see my screen. What I will do today is talk a bit about lung fibrosis and pulmonary hypertension in this disease. So I think before we talk about it, it's important to understand what is the role of lungs in the human body. And here are a few slides that I've taken from Google. And I just want to highlight for everybody who's listening that, there are two roles that the lung play out here. And the first one that we are very well aware of is that you take a deep breath and all of us have two lungs. The right part of the lungs have 3 lobes and the left part of the lungs have 2 lobes. And you take a deep breath, and at the end of these 3 limbs, like I call, or the arteries and the veins that you see out here, there's a
मैंने बोला तो था मैं खाती रही हूँ, अपना पूरा ख्याल रख रही हूँ, ऑक्सीजन मेंटेन 3 बार.
Sorry, Dr. Khanna. Sorry.
That's okay. There are alveoli out here, which are air sacs. So all of us have these air sacs, which are covered by these arteries and veins. So when you take a deep breath, the oxygen goes into the air sacs and diffuses into these vessels that are around these air sacs, and then the carbon dioxide or the deoxygenated oxygen comes out and you breathe out. And that's what we do, breathe in and breathe out with our lungs. And this is a picture, this is a slide of a normal lung, a person who had an autopsy, and you can see the lung tissue almost looks like a piece of chicken, turkey, meat, whatever you want to call it. And within that, there are large vessels that you see within dispersed throughout the lung tissue. Another way to look at the lung is to do a CAT scan or a CT scan, and we'll talk quite a bit of the role of CT scan here. On the left is a person with Scleroderma who does not have lung fibrosis. You see clearly the heart tissue out here. You clearly see out here the left side of the lung and the right side of the lung here. And you see that the trachea, the oxygen tube, is divided into 2 parts out here. So this is the left side of the lung. This is the right side of the lung that you see here. On the other hand, what you see on the right side out here are all the vessels that are going into the lung tissue. So it's an interconnection between the parenchyma or the tissue or the structure of the lung and all the blood vessels, which I showed you out here. So that's how you have to think about the lung tissue. And whenever you have lung fibrosis, which is scarring of the lung, or pulmonary hypertension, which is scarring of these vessels that are going in there, you will have decreased oxygenation. So if I destroy all these air sacs out here, or if I destroy all the vessels that are going into around the air sacs, you will get shortness of breath, decreased oxygenation. And I see some of you are actually using oxygen in India. So let's talk about what happens in lung fibrosis. Lung fibrosis is also known as pulmonary fibrosis, interstitial lung disease. It is really the scarring of the lung. So if you see in this photograph or the picture that I've included here, you see all the scarring that is happening out here within the lungs that is really destroying these air sacs or alveoli that I talked about. Here's a patient of mine in Michigan who has lung fibrosis, and what you see out here is this part of the cursor you see is normal lung. Here's a person's heart. So you see the heart, you see the spine out here, but what you see out here is that the lung has been destroyed out here because of the fibrosis. And what you see here is that the sacs, the small sacs that I showed you before, you cannot see them properly anymore out here. And I just wanted to highlight those for you, the destruction of the sacs out here. What you see on the right side is a photograph of a person who unfortunately died because of lung fibrosis. And again, what you see out here is quite a bit of destruction within the lungs. And when there's a destruction and fibrosis within the lungs, the air sacs and the vessels get destroyed. And that's why you require oxygen and other therapies. So I think it is important as a patient to be your own advocate. As the previous doctors highlighted, scleroderma is very rare. In US, which has a population of about 1/4 of India, there are only 100,000 people who suffer from systemic sclerosis or scleroderma. And there's a population of 350, 400 million people who live in the United States. What I want to highlight out here is a photograph here. Just give me a minute. Let me just gonna hide this. Okay, I'm back. So I want to share with you out here what to expect. I want you to focus on the last part of the slide. And I want to highlight for the patients in India that the reason people die due to scleroderma earlier is because of pulmonary hypertension, which is shown out here, and pulmonary fibrosis. So the involvement of the lung tissue, whether it's because of pulmonary hypertension or is it because of lung fibrosis, is a leading cause of death. But there are things that you can do, your doctors can do to help you treat this, to help you hopefully prevent it from getting progressive disease. So here's a patient of mine. I showed you the lung, and you see the difference out here. You see quite a bit of scarring in the lung tissue. Here's the heart of the person, here's the spine of the person. But what you see compared to the previous CAT scan that I showed, or the CT scan, you see white linings out here. This is all scarring that has happened because of the lung fibrosis. So when I say ILD is a medical term that we use for lung fibrosis. 70% of patients, 7 out of 10 people who have systemic scleroderma will develop lung fibrosis, unfortunately. However, the good part is that only 2 or 3 out of 10 will develop progressive lung fibrosis that may require treatment, oxygen therapy, and things like that. One of the challenges of lung fibrosis is that it is largely irreversible. So one of the key issues that happens is that when you have scarring of the lungs, it impacts your lung function. It causes scarring and you're not able to take deep breath. You might have chest pain, shortness of breath, and cough. But the disease is irreversible. So the role of the doctors and one of the teachings that I do in India and other countries is that we need to diagnose lung fibrosis early in people with scleroderma so we can treat early and stop the lung fibrosis from getting worse. So here's a slide. There are 2 kinds of scleroderma. I'm sure the previous speakers have talked about. One is called diffuse cutaneous scleroderma, which has a lot of skin involvement. And then there's called limited cutaneous scleroderma, which has a little bit of lung involvement. Skin involvement, I'm sorry, a little bit of skin involvement, but that doesn't matter because both of them get lung fibrosis, and lung fibrosis is an earlier complication. Now, what I've seen in India, I sometimes come to India and I see patients in Delhi with my other colleagues, that people do not go to doctors early on and they wait and they start to see the skin is getting darkened, which is very common in Indian people with scleroderma, that there's quite a bit of darkening of the skin. But the lung fibrosis occurs usually in the first 3 to 5 years after onset of your disease. So if you start developing Raynaud's, you start developing thickening of the skin, sores over the fingers, the time has started for developing lung fibrosis. And there are antibodies that I suppose Dr. Rath talked about that may predict who will develop bad lung fibrosis. So there are these antibodies that you can do at Lal Labs or any labs in India. And if you have this antibody called SCL70 or topoisomerase 1, which is very common in India, Dr. Shinoy is leading a large scleroderma registry throughout India. And if you have diffuse type of scleroderma, the risk of having severe lung fibrosis is quite large if you have this antibody. So if you're newly diagnosed with scleroderma and these antibodies have not been checked in you, I would strongly recommend that you talk to your rheumatologist and other doctors so they can test it. Now, once you have lung fibrosis, so I told you 7 out of 10 people will develop lung fibrosis, out of which 3 out of 10 will develop progressive lung fibrosis. The decline of the lung function happens in the first 4 years after onset of lung fibrosis. And the only way, again, to detect whether you have lung fibrosis or not, and this is not an interactive session, would be a CT of the chest, a CAT scan of the chest. And I don't know how many of you ever had a CAT scan, or if you had CAT scan very early on in the disease. So let's talk about diagnosis. Most of the people, and unfortunately doctors, wait for symptoms to occur. And the most common symptoms are you are short of breath. So the classical symptom here would be that you're climbing up the stairs, or you're going to the mall or the shopping center and you're walking around going shopping, and you're getting more and more short of breath and you have to stop. Or you start to get cough at night, you're coughing quite a bit at night, you keep on waking up coughing at night or coughing during the day. And the doctor gives you antibiotics, the doctor says that you need to breathe clean oxygen, move out of daily because of the pollution and everything. The second part that is done quite a bit is something called lung function test. And then I'll talk about the CT of the chest. Now, the problem with symptoms is it is very late in the disease. Once 20 to 30% of your lung has been affected. So the people start to get symptomatic, they start to get more and more short of breath when you get quite a bit of lung fibrosis, when those air sacs that I showed you are starting to get destroyed. But scleroderma people may be short of breath due to other reasons. You might have heart involvement, pulmonary hypertension, you might have acid reflux. The acid from the stomach, if you're sleeping flat at night, may be going into your lungs, and that's why you're waking up at night coughing. If you're going to take one thing out of this lecture, every scleroderma patient should be sleeping at an angle at night. And, we can talk later on, what to buy, but it is called a wedge pillow, or you raise the head side of the bed with a couple of breaks. It could be due to muscle involvement and other causes. So you cannot just rely on shortness of breath being symptom that states that you have lung fibrosis. I'm assuming all of you get pulmonary function test. Every scleroderma patient during the first 5 years of the disease should get a lung function test every 6 months. You should be getting your rheumatologist should be ordering the lung function test every 6 months. And the lung function tests are very, very helpful because they tell you the normal function of the lungs, the air sacs, the vessels that are supporting the air sacs. And we can look at the different parts of the curve here that can tell us if somebody's a smoker, or somebody has an asthma, or somebody has COPD. That will look very different compared to if you had lung fibrosis. So these patterns can tell us, the values that we see can tell us quite a bit whether you have, a normal or abnormal function. However, the lung function test does not tell you if you have pulmonary fibrosis, because there could be many, many other reasons that you could have abnormal lung function. That may include, like I said, asthma. That may include that you didn't do the lung function test properly. You are unable to do it properly. So you cannot rely on lung function test to make a diagnosis of lung fibrosis. So it's usually done by lung doctors. It takes about 30 to 90 minutes. The biggest issue with the lung function, although it's very helpful, is that the normal lung function range can be between 80 to 120%. And I'll show you one lung function from my patient. And that can cause confusion among the patients and the doctors. It can be normal in 25% of patients with lung fibrosis. And the most common reason for an abnormal lung function with no lung fibrosis is, here's a patient of mine who's doing lung function. And you can see when you have scleroderma, the mouth gets smaller, and you're not able to put the mouthpiece into your mouth, and the air might leak out, or you're unable to form a seal out here. You also have to close your nose so no air leaks out of the nose. So here's a patient of mine with lung function, and I will point to you just to 2 or 3 values. The first one is called forced vital capacity. It's a medical term, and it says how much are you able to blow out in 6 seconds. You take a deep breath in and you blow out for 6 seconds. And you can see that it tells you what her lung function is in liters, what it should be for her age, gender, and whether she's Indian, American, whatever it may be, and what is the person predicted. So I told you 80 to 120% is normal, and she has 89%. She's not short of breath. If I was just looking at the lung function and symptoms, I would not have done anything and waited for her lung function to continue to decline. She had moderate lung fibrosis. The other one we look at is the diffusion capacity, which is a diffusion of the air between the air sacs and the blood vessels. So again, lung function can be normal in early scleroderma lung fibrosis, or it can be abnormal because you just didn't do it right, or there's muscle weakness, or they didn't teach you right how to do it. So you cannot just trust on lung function to make a diagnosis. However, once you have lung fibrosis, lung function is very, very helpful to follow you up whether the drugs are working for you or not. So again, you should be getting a lung function test every 6 months, at least in the first 3 to 5 years. So I started my medical training in 1990s in Delhi, and then I went to Los Angeles, UCLA, and the things have changed, how we used to treat scleroderma in 1990s and how we treat them now. At least in 1990s, we used to do a X-ray of the chest. So you took a picture of the X-ray of the chest and you said, okay, whether the patient has lung fibrosis or not, or whether they're symptomatic, they have symptoms. Now we do CT on everybody. A patient with scleroderma comes, whether you have symptoms or not, whether your lung function is normal or not, we do a CT of the chest to try to diagnose. So you can see a lot of lung fibrosis here, destruction, a lot of hair, and a little bit of lung fibrosis here. We want to capture people with early lung fibrosis and with this antibody that I talked about, so we can treat you early. Now, the biggest reason that your doctors don't do CT of the chest is because of radiation. So the reason you're not getting a CT of the chest every time, and I'm not saying you need to get it every year, but when you are diagnosed with scleroderma, is because they're worried about radiation that they may be giving. So let me give you some data on how much radiation you get. That's what happened. Okay. So we're just going to focus on USA because that's where I work and that's where the data is. All of us get radiation because we live on the earth. And in US and same in India, the amount of radiation you get is 3 units. It doesn't matter what it is, it's about 3 units. If you get a CT of the chest, which is called high resolution CT of the chest, you get the same radiation. So the amount of radiation that you are getting is similar to what you will get on ELD basis if you lived in US, which is 3 millisievert. It's important for patients to know that this is the only way to diagnose lung fibrosis. So I am willing to take that radiation one time to make sure to get a CAT scan of the chest to see whether there is fibrosis or not. There's no reason to do a CAT scan every year in a patient with scleroderma and lung fibrosis unless your disease is getting worse and you're getting more short of breath. So here's a patient of mine. You can see a little bit of lung fibrosis here, and then here's a patient that, you saw something, but you turned the patient over and there's no lung fibrosis. So CT of the chest is very, very important and the only way to diagnose lung fibrosis. Now, the treatment of lung fibrosis is pretty clear, but can be challenging. So the best thing that you and your doctors can do is to diagnose lung fibrosis early. So let's say you have lung fibrosis now, then we have to see whether you have a little bit of lung fibrosis, like this patient, or you have a lot of lung fibrosis. Do you need oxygen? Or you don't need oxygen? Do you need other immunosuppressive therapies? There is no data to support that Ayurvedic therapies or homeopathic therapies and all these therapies do anything for lung fibrosis. So a lot of patients in India go to Ayurveda, go towards homeopathic and everything. And unfortunately, they're able to diagnose lung fibrosis early, but then it becomes progressive and it keeps on getting worse and worse before you go to the allopathic medication. Make sure you get all your immunization, your flu shot, your pneumonia shot, your COVID vaccine. It's very, very important in people with lung fibrosis. If you get COVID or other pneumonias within that damaged lung, you can get into trouble. You want to keep your oxygen above 88% when you walk, and there are ways to test it with your pulmonologist. And make sure you manage your GERD. GERD is a medical term for heartburn. You sleep at an angle, you take your proton pump inhibitor or the other therapies for this. So there are 2 kinds of therapies that we use for lung fibrosis. And these are the terms or the drugs that you have used. This is called mycophenolate mofetil. This is the most common drug that is used in the US by 70% of people who have lung fibrosis. Every lung fibrosis early on should be treated because you want to prevent the lung fibrosis from getting worse. You can think about a scar. You want to treat the scar. You don't want the scar to get bigger and bigger and cause a lot of scarring. So the therapies that we use are called immunosuppressive therapies. All of them suppress your immune system. In India, it's very important for the doctors to rule out tuberculosis and others, which is not common in US, but it's common in India. So these are the therapies that we use: CellCept, chemotherapy, Cytoxin, Rituxan. A lot of Rituxan is used in India. I know, having seen patients there, and a new drug called Actemra or tocilizumab. All of these therapies are immunosuppressive therapy. They calm down the inflammation in the lungs. But the only way to figure out whether the drugs are working is to do regular pulmonary function tests to look for stabilization of the forced vital capacity I talked about. If you continue to have progressive lung fibrosis, in other words, you're taking the drugs and the drugs are not doing much, or they're doing a little bit, but the lung function is declining, then we can add the drugs such as pirfenidone and nintedanib, which are both available in India. So you can take chemotherapy, Cytoxin. I can answer questions by mouth every day or by IV. You can take this drug called mycophenolate, which we use quite a bit here. You can use rituximab, you can use tocilizumab, you can use nintedanib, Ofev. And I know that it's not very common in India, but we do stem cell transplantation and lung transplantation in US. So I will stop there. Again, the take-home message out here for the patients who are listening are, if you have a new diagnosis of scleroderma, the one thing that I would ask your rheumatologist and your lung doctors is to do a CT of the chest. You need to do lung function tests on a regular basis. Starting these therapies does not mean that the lung fibrosis is going to go away. There's nothing you can do once you have lung fibrosis. It will stay with you for the rest of your life. What you can do with the fibrosis is that you can try to stop it. You can try to calm it down a little bit so you're able to function properly. So now I'll talk very briefly on pulmonary hypertension, because pulmonary hypertension, again, all of these are linked. Pulmonary hypertension is high blood pressure of the lungs. So when you take your blood pressure, how do you take your blood pressure? You put a cuff around your arm and you take your blood pressure. And that blood pressure is you're taking from the large vessels that are coming from the heart and going around the body. Pulmonary hypertension is taking blood pressure of the lungs. Think about putting a cuff around your lungs. And that's where the pulmonary pressure is. And I think to understand pulmonary hypertension, you have to understand that there are big vessels such as aorta, the largest vessel in the human body, and the heart is a pump, and the heart has a left side which is more strong than the right side of the heart. And if there are issues with the pumping or it's issues within the lungs, people can develop pulmonary hypertension. So we talked about those the air sacs that I showed you before. And you remember in those air sacs, what I told you, that you could get short of breath if the sacs are destroyed due to fibrosis, or you can get short of breath where those arteries that are around those air sacs start to get damaged. And you can see the most common cause of pulmonary hypertension is scleroderma. It's one of the most common cause of pulmonary hypertension. And if you can think about these small vessels and the flow of the blood that is going on, and now you start to cause scarring out here because of scleroderma. Suddenly, it is like a monsoon in India where the streets are getting filled and overflowing and the blood is just not able to flow. And you start to get restriction of the blood that is going to exchange between the air sacs and within the blood vessels. So pulmonary fibrosis is having damage of the air sacs. Pulmonary hypertension generally is damage of the blood vessels that are around the air sacs. So you can imagine that both of them will decrease your lung function. Both of them will cause shortness of breath. However, the treatment are very different depending upon what is causing that shortness of breath. Now, one of the key problems with pulmonary hypertension is that pulmonary hypertension can happen due to many, many reasons, and I'll show you. It can happen due to lung fibrosis. It can happen due to, if your left side of the heart is not functioning fine, the pump is not functioning, or it can happen due to scleroderma and other connective tissue diseases. The only way to diagnose pulmonary arterial hypertension, and I know it's not done in India very much, is right heart catheterization, and we'll talk about that. So unlike lung fibrosis, which occurs early in the disease, pulmonary arterial hypertension is a later complication. So you have to understand, Diffuse scleroderma patients get more ILD, limited scleroderma patients get more pulmonary arterial hypertension. They both can get it, but it is more common in limited scleroderma patient. So that's very important that once you get short of breath later with your scleroderma, it's more likely to be pulmonary arterial hypertension and not ILD. So look at the symptoms that people have. These are 2,000 people, shortness of breath. Now, shortness of breath can happen because you have lung fibrosis, fatigue, chest pain, lower swelling of the legs, fainting, dizzy, cough, palpitation. So you can see all these symptoms. And the problem with these symptoms is that all these symptoms can be caused by lung fibrosis. All these symptoms can be caused by because you have autoimmune disease. So it becomes very, very difficult to make a diagnosis of pulmonary hypertension just on symptoms. So what people usually get is echocardiogram. I'm sure all of you had gotten ultrasound of the heart. The recommendation is that if you have scleroderma, you should get it every year, period. You need to get an echocardiogram every year by a cardiologist. So the echocardiogram gives you an image of the heart, and it divides the heart into the left side and the right side. And you can see the left side of the heart is much bigger than the right side. What you see is here's a patient of mine who has severe pulmonary hypertension. And you can see that the right side of the heart is much, much, much bigger than the left side because of pulmonary hypertension. So you can see how the heart is beating, but you can see that the right side of the heart compared to the normal heart out here is much, much bigger because of the increased pressure from the pump and increased pulmonary artery pressures in the lungs. So what I advocate, echo is good, but echo should be done every year, whether you have symptoms or not. So I want to take that home. CT of the chest should be done at the first visit, whether you have symptoms or not. Echo should be done every year, whether you have symptoms or not. That is called screening. Once you start to get symptoms, you go towards diagnosis or not screening. The problem with echo is that echo misses about 1/3 of the patients who have pulmonary hypertension. So you can't just look for echocardiogram to make a diagnosis. Again, like I stated before, pulmonary hypertension could be due to pulmonary arterial hypertension, which is on the right side of the blood. It can happen. Here's a patient of mine with a lot of lung fibrosis. Once you damage the parts of the lung, the air sacs, the vessels get destroyed. And you can develop pulmonary hypertension due to that, or you can develop when the heart is getting stiff and not moving well. So the diagnosis is made by a right heart cath, where a cardiologist put a catheter into the right side of your heart through either the neck or the groin. I know it is not done in India, but this is the gold standard. This is how we diagnose pulmonary hypertension and early pulmonary hypertension. You want to diagnose pulmonary hypertension because once the heart fails, there's not much you can do to reverse the heart failure. It's similar to lung and heart. Once lungs and heart fail, you can't do anything to revert back the damage that has happened. It's like having mini heart attacks all the time. So you really need to diagnose it early. Now, the beauty and the advantage is that there are a lot of therapies that are approved in India that can be treated. So there are endothelial blocker. These drugs are called bosentan, macitentan. There is Viagra that is used. There are prostacyclin. There are a lot of therapies that are available to people in India for management of pulmonary hypertension. And here are a few drugs that I've written. These are the drugs that are approved in US, but all these drugs are available in India and can be given by your rheumatologist. I think the key thing that other doctors have mentioned is that the way to treat, and Dr. Kaushik said that, and Dr. Shefali said that, and Dr. Shinoy said that, we all agree that rheumatologist is just one part of the spoke out here. The role of the pulmonologist, the role of your social worker, physical therapist to make you strong, psychologist to help deal with scleroderma, the depression that comes with scleroderma, this long-standing scleroderma, your regular doctor that can help you manage day-to-day activities, give you flu shots and things like that, is absolutely critical in managing this disease. So I will stop there.